1, 2,
And
Patients here.
female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Where the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Right now, a condition exists that affects up to 16% of all pregnancies.
Yeah, and it's actually the leading cause of maternal mortality in the United States.
Right, like responsible for nearly a third of all maternal deaths. And yet, the most common warning sign, the very first alarm bell that something is just catastrophically wrong, is something millions of people brush off every single day.
I mean, a simple headache.
Exactly, just a headache.
It is a terrifying reality.
Yeah.
You know, and honestly, it is the ultimate test of clinical judgment for anyone stepping onto an obstetrics floor.
Totally. So listen, if you are staring at a massive stack of nursing textbooks right now, or, clinical charts and ATI modules, and you're just wondering how on earth you're supposed to memorize 1,000 different disconnected symptoms, take a deep breath.
Seriously, take a breath. You're in the right place.
We are taking that mountain of maternal newborn information and we're applying the Pareto principle to it. We're going to sift through all the noise and find that foundational 20% of knowledge that will give you 80% of the value on your exams.
And more importantly, in real-world patient care.
Yeah, absolutely.
Because I'm approaching this deep dive as your clinical mentor today. We aren't going to just, recite a list of symptoms from a textbook. That doesn't help anyone.
Right, you can just read that yourself.
Exactly. I am going to show you the specific traps exam writers love to set. I'll explain the physiological why behind every single finding and help you shift from rote memorization to actually thinking like a safe, elite future nurse.
Which is incredibly relieving, to be honest, because looking at the material for hypertensive disorders of pregnancy, it just looks like a random assortment of data points.
Oh, I know, it's overwhelming.
Like headaches, swollen ankles, right upper quadrant pain, blurry vision, reflexes. As a student, my instinct is just to make 100 flashcards and try to, brute force memorize them.
Yeah, throw the flashcards away for it.
Okay, it's done.
The biggest mistake students make with hypertensive disorders of pregnancy is that they immediately focus on the blood pressure cuff.
Well, yeah, it's in the name.
Right, they look at the numbers. But if you want to understand this disease, you literally have to ignore the hypertension at first.
Wait, really? Ignore the blood pressure?
Yes, the high blood pressure is just a symptom. To understand the pattern, you have to understand the plumbing, specifically the placental plumbing.
Okay, the plumbing.
Because if you understand how the pipes are built, every single symptom, every lab value, and every medication suddenly makes perfect logical sense.
Okay, I love that approach. So before we even talk about diagnosing someone with high blood pressure, let's talk about the root of the problem.
Let's do.
What is actually happening in a healthy pregnancy with the plumbing? Because the maternal body has to undergo some massive changes just to support a growing fetus, right?
Oh, massive. A pregnant person's blood volume increases by roughly 40 to 50%.
That is a wild amount of extra fluid.
It is. And to handle that sheer volume of fluid without blowing out the entire cardiovascular system, the pipes have to adapt. The genesis of everything we are talking about today starts in the spiral arteries of the placenta.
Spiral arteries, okay. What exactly are those doing?
Think of them as the primary supply lines. In a normal, healthy pregnancy, these spiral arteries extend from the mother's uterine muscle through to the decidua, which is the lining of the uterus.
Okay, got it.
And as the pregnancy progresses, specialized fetal cells, which are called trophoblasts, literally burrow into that uterine lining.
They just dig right in there.
Exactly. And when they invade, they force those maternal spiral arteries to completely remodel themselves.
Remodel how? What's the actual structural change happening?
They change from narrow, thick-walled, tightly coiled tubes into wide, thin-walled, sac-like funnels.
Okay, so they open up.
Yeah. Picture a stiff, narrow drinking straw transforming into a wide, flexible hose. This massive widening is crucial because it significantly decreases vascular resistance.
Ah, okay. Wider pipes mean less resistance.
Right. It allows the maternal heart to pump huge volumes of blood directly to the placenta at a very low pressure.
So wide pipes, low pressure, maximum blood flow to the baby. That makes complete sense. That's the ideal state.
That is the goal.
So what goes wrong in the plumbing to cause preeclampsia then?
In preeclampsia, that fetal cell invasion, the migration of the cytotrophoblasts, is insufficient. It just fails.
Oh, so they don't burrow in deep enough?
Exactly. The spiral arteries never receive the signal to remodel properly. They don't turn into those wide, thin-walled funnels.
So they stay narrow?
Yes. They remain thick-walled, narrow, and stiff.
Okay, let me visualize this. We still have that massive 50% increase in maternal blood volume, right?
Right. The body is still making all that extra blood.
So the body is pumping all this extra fluid, but now it's trying to force its way through narrow, stiff pipes that refuse to dilate.
You've got it.
It sounds exactly like putting your thumb over the end of a garden hose. Like, the volume of water coming from the spigot hasn't changed at all.
Yep.
But because the exit is restricted, the pressure inside the entire hose system just skyrockets.
That is a brilliant clinical analogy. The pipes are fundamentally stressed, and because the vessels are so narrow, we have decreased placental perfusion.
Meaning the water isn't getting out of the hose.
Exactly. The fetus isn't getting enough oxygen or nutrients. We have fetal hypoxia. And more importantly, for the maternal pathophysiology, the placenta itself becomes ischemic.
Ischemic, so it's starving for blood.
It is literally starving for blood.
And I'm assuming a starving placenta doesn't just, quietly accept its fate.
Oh, not at all. It panics aggressively.
Yeah.
The ischemic placenta essentially sends out an SOS, but it's a highly destructive one.
Destructive how?
It starts secreting toxic substances and inflammatory cytokines directly into the mother's systemic bloodstream.
Oh, wow.
Yeah, and this is the critical turning point of the entire disease. Those toxic substances circulate through the mother's body and cause widespread, generalized endothelial cell dysfunction.
Endothelial cell dysfunction. Okay, that's a heavy clinical phrase. Break that down for me. The endothelium is the inner lining of the blood vessels. Right?
Exactly. It's the inner wallpaper of every blood vessel in the mother's body.
Yep.
And these toxic placental cytokines are essentially acting like acid on that wallpaper. The endothelial cells get damaged, inflamed, and irritated.
So the pipes are literally damaged from the inside out.
Yes. And why this is the absolute most important concept for you to grasp for your exams is this. Damaged endothelial cells lose their ability to relax.
They lose their elasticity.
Right. Instead of relaxing, they clamp down. This causes generalized vasospasm all over the mother's body.
So going back to the garden hose analogy, it's not just that my thumb is over the exit anymore.
Yep.
Now the entire length of the hose all throughout the body is violently constricting and shrinking.
Yes. And that increased peripheral resistance, the entire cardiovascular system clamping down, is what causes the hypertension.
Oh, wow.
This is exactly why I tell my students that preeclampsia is not a high blood pressure disease.
Yeah.
High blood pressure is just the most visible alarm bell ringing.
That is a massive perspective shift. So the high blood pressure isn't the villain, it's just a symptom of the generalized vasospasm.
Precisely. The real villain is the damaged, clamped down blood vessels suffocating the organs. Mm-hmm. Because of this systemic vasospasm, there's incredibly poor tissue perfusion to all of the mother's organ systems.
So her whole body is starving for oxygen.
Yeah. The brain, the liver, the kidneys, the eyes, they're all being starved of blood and oxygen because the vessels feeding them are spasming and clamped shut.
Okay, that changes everything.
When you understand this, you do not have to memorize a random list of symptoms. You logically know that if the renal vessels spasm, the kidneys fail.
Right.
If the retinal vessels spasm, the patient gets blurry vision. It all stems from the broken plumbing and the damaged wallpaper.
That makes the pathophysiology so much clearer. It really does.
Yeah.
So if the vascular plumbing is broken and pressure is building, how do we know if it was caused by the pregnancy or if the patient just already had bad pipes before they conceived?
Which happens all the time.
Right, because people have chronic high blood pressure every day.
That is exactly the question exam writers want to see if you can answer. The diagnosis and classification of hypertensive disorders in pregnancy completely revolve around one specific, unmovable date on the calendar.
Okay, what's the date?
It is the 20-week gestation mark.
The 20-week mark. So literally halfway through a standard 40-week pregnancy. Why is that specific week so important?
Because of the timeline of placental development and that spiral artery remodeling we just talked about. If hypertension shows up before 20 weeks, the placenta hasn't really had time to establish that toxic cascade yet.
Oh, okay. So it couldn't be the placenta's fault yet.
Exactly. Therefore, We categorize blood pressure exceeding 140/90 millimeters of mercury before 20 weeks gestation as chronic hypertension.
Meaning they already had it. The pregnancy didn't cause the vascular issue. The patient simply brought their pre-existing hypertension into the pregnancy.
Exactly. Or, they had it for years and it just went undiagnosed until their first prenatal visit.
Which is pretty common.
Very common. If a patient walks into the clinic at 12 weeks pregnant and their blood pressure is 145/92 on 2 separate readings, that is chronic hypertension.
Do we treat that differently?
Yes. The latest guidance from the American College of Obstetricians and Gynecologists recommends initiating medical therapy right at that 140/90 threshold to protect the mother from long-term sequelae, like acute renal failure or a stroke.
Are patients with chronic hypertension at a higher risk for their plumbing breaking further as the pregnancy progresses?
Significantly. About 20 to 25% of these patients will go on to develop what we call superimposed preeclampsia.
Oh, superimposed, meaning the preeclampsia stacks on top of their chronic condition.
Right. Their already stiff pipes are subjected to the inflammatory cytokines, and things get much worse. They require intense, continuous monitoring.
Okay, but let's look at the other side of that 20-week boundary. What happens if a patient has perfect blood pressure, like 110/70, for the first half of their pregnancy, but at week 28, it suddenly spikes to 142/94?
Because it's after 20 weeks, the pregnancy itself is now the suspected cause. So that would be gestational hypertension.
Gestational hypertension.
Got it. Correct. It's defined as new-onset blood pressure greater than 140/90, occurring after 20 weeks gestation in a previously normotensive patient.
Okay.
But here is the critical clinical caveat that you must memorize. To be purely gestational hypertension, there must be NO, proteinuria, and NO signs of systemic organ damage.
So it's literally just the numbers on the monitor. The pressure is up, but the organs aren't failing yet.
Right. Structurally, we look for that elevated pressure on at least 2 occasions, 4 to 6 hours apart.
Why the wait?
We want to make sure it wasn't just a spike because the patient, rushed into the clinic from the parking lot.
That actually brings up a good point about nursing skills. How easy is it to get a false reading here? I imagine taking the blood pressure correctly is vital when the diagnosis hinges on a few millimeters of mercury.
It is absolutely vital. If you use a cuff that is too small for the patient's arm, you will get an artificially high reading. If you take it while they are lying flat on their back, or while their legs are crossed, or while they are actively talking, the reading is practically useless.
So what's the gold standard way to take it?
The patient needs to be seated, resting quietly for at least 5 minutes. Feet flat on the floor with the arms supported at heart level.
That makes sense.
As a nurse, you cannot blindly trust a machine's automated reading if it dictates a life-altering diagnosis. Always recheck manually if the numbers are borderline.
Okay, let's play out a scenario. Let's say I have a patient, Maria. She is 30 weeks pregnant. Her blood pressure is 145/95.
Okay.
Her urine is totally clean, no protein. Her labs are perfect. She has gestational hypertension. What am I telling her? Is she staying in the hospital?
For pure gestational hypertension, it is generally considered a temporary expected complication that we can manage conservatively.
So she can go home.
Yeah, we tell Maria that this usually disappears within 12 weeks postpartum. We might place her on modified bed rest at home.
Okay, but we're giving her homework, right?
Oh, absolutely. We teach her how to do daily fetal kick counts to ensure the baby is active and thriving. We might have her take her own blood pressure twice a day and bring a log to her weekly clinic visits.
But we are giving her a very strict list of warning signs, right? Because we know those pipes are under pressure and we are just waiting to see if they start to leak.
Exactly. We are teaching her the alarm symptoms.
Which are what?
We tell Maria, listen, if you suddenly feel a severe headache that won't go away with Tylenol, if your vision gets blurry or you see flashing spots, if you feel a burning pain under your right rib cage, or if the baby stops moving,
Yeah.
you do not wait.
You come in right away.
You come to triage immediately. Because those symptoms mean the endothelial damage is progressing. The disease is crossing the line.
Okay, before we cross that line into preeclampsia, I want to test my understanding of the timeline rule. I'm going to set up a scenario, and I want you to tell me if I'm interpreting it right.
Lay it on me.
A patient comes into triage. She is 18 weeks pregnant. She's complaining of a mild headache. Her blood pressure is 146/92. The doctor diagnoses her with gestational hypertension because she is pregnant and her pressure is high.
I am stopping you right there. And honestly, if this were a clinical rotation, I would pull you aside.
Wait, what? Why?
That diagnosis is dead wrong.
But the pressure is high. And she's pregnant.
Look at the calendar. 18 weeks. What did we just establish?
Before 20 weeks.
Exactly. Before 20 weeks means it is chronic hypertension. Pin that 20-week rule to your brain.
Wow, okay. That's tricky.
It is one of the most common distractors on nursing exams. They will give you a recitation of 16 weeks, 18 weeks, 19 weeks, and a new high blood pressure, and list gestational hypertension as option A.
Oh, I would totally pick that.
Most students do. It's a trap. They had the hypertension before, and the pregnancy is just unmasking it now. 20 weeks is the ironclad wall.
Okay, lesson learned. 20 weeks is the wall. Now let's go back to our patient, Maria.
All right, Maria at 30 weeks.
Right. She was at 30 weeks with gestational hypertension. She calls triage 2 weeks later. She says her blood pressure at home is now 150/100, and her hands are so swollen she literally can't make a fist.
Oh, boy. Okay.
We bring her in. What are we looking for to see if she has crossed the line into preeclampsia?
We are looking for the definitive signs that the systemic vasospasm and endothelial damage are now actively destroying organ systems. Historically, the classic definition of preeclampsia was new-onset hypertension after 20 weeks, PLO-US proteinuria.
Protein in the urine. How exactly does high blood pressure and broken plumbing lead to protein leaking into the toilet?
It goes right back to the endothelial damage. The kidneys filter blood through millions of microscopic clusters of capillaries called glomeruli.
Okay.
These capillaries are lined with those endothelial cells. When the toxic cytokines damage the endothelium in the kidneys, the capillaries become leaky. The filtration barrier breaks down.
So it's not filtering properly.
Right. Protein molecules, which are normally way too large to pass through the filter, suddenly spill out of the damaged blood vessels and into the urine.
It's literally the plumbing weeping. How much protein are we talking about here?
Clinically, we define it as 300 milligrams or more in a 24-hour urine collection, or a 1+ or greater reading on a simple urine dipstick.
But wait, I remember reading in the sources that the definition of preeclampsia recently changed. You don't actually need protein in the urine to make the diagnosis anymore, right?
That is a phenomenal point and a vital update to clinical practice that exams absolutely love to test. You can still have a definitive diagnosis of preeclampsia without proteinuria, if that hypertension is accompanied by other clear signs of maternal organ failure.
So if her kidneys are miraculously holding up, but her liver is failing, it's still preeclampsia.
Exactly. If the liver enzymes are sky high, or the platelets are crashing, or she has fluid building up in her lungs, the diagnosis is preeclampsia.
So it's the systemic damage that defines it now.
Yes, the multi-system damage is the key, regardless of which specific organ takes the hit first. Now, clinically, we have to differentiate between two distinct levels of danger here. Preeclampsia without severe features, and preeclampsia with severe features.
Okay, let's break those down. Maria comes in, her BP is 150/100, she has 1+ protein in her urine, but her blood work is otherwise normal and she says she feels okay.
That is preeclampsia without severe features. We're elevating her care, but we might still be able to manage her conservatively.
So what's the goal there?
The goal is a delicate balancing act. We are in a watch-and-wait holding pattern. We want to buy the fetus as much time as possible to mature in utero without putting the mother's life in immediate jeopardy.
So lots of lab work.
Oh, tons. We monitor her lab, CBC, liver enzymes, kidney function very closely.
But what does it look like when the dam breaks? What are the actual severe features?
The severe features mean the disease is accelerating out of control. First, the blood pressure takes a massive, terrifying leap. We are looking at sustained readings of greater than 160/110 millimeters of mercury, taken on 2 occasions, at least 6 hours apart while the patient is resting.
160/110. That is stroke territory.
It is. The pipes are under catastrophic pressure. And this is accompanied by profound systemic symptoms. Remember that vasospasm in the brain we talked about?
Right, the cerebral edema.
Yeah. The cerebral vessels are clamping down and leaking fluid, causing that edema. The patient will complain of severe, unremitting headaches that do not respond to medication like Tylenol.
Wow.
They will also experience blurred vision or scotomata.
What exactly is a scotoma? Like, what is the patient actually seeing?
They will describe seeing dark blind spots or shimmering, flashing lights in their visual field.
That's terrifying. Why does that happen?
It's because the microscopic retinal blood vessels are spasming and literally starving the optic nerve of oxygen.
That has to be so scary for the patient. What about the lungs? You mentioned fluid building up there too.
Yes, pulmonary edema. The endothelial damage causes the pulmonary capillaries to leak fluid directly into the alveolar spaces in the lungs.
So they're filling with water.
Right. When you listen to their lungs with your stethoscope, instead of clear air movement, you will hear crackles or wet wheezing. The patient will feel short of breath or feel like they're drowning from the inside out.
And the kidneys, what happens to them when it's severe?
The renal vasospasm chokes off blood flow to the kidneys, leading to oliguria, which is severely decreased urine output.
How little are we talking?
Often less than 500 milliliters in a 24-hour period. The kidneys are literally shutting down.
Okay, let's talk about the swelling, because Maria complained that she couldn't make a fist. Swelling is normal in pregnancy, though, right? Like, my sister's ankles were massive when she was 38 weeks pregnant.
You have to know how to differentiate expected swelling from dangerous swelling. What your sister had was dependent edema.
Dependent meaning depending on gravity.
Exactly. When you have 50% more blood volume and a heavy uterus pressing down on the pelvic veins, gravity pulls that fluid into the lowest points of the body.
Right.
If you stand on your feet for an 8-hour shift at 32 weeks pregnant, your ankles are going to swell. That is an expected normal finding.
Gravity doing gravity things?
Yep.
So what makes Maria's swollen hands different?
Because gravity doesn't pull fluid into your fingers when your hands are resting at your sides, and it certainly doesn't pull fluid into your face.
Oh, right.
Non-dependent edema is a massive red flag. If a patient says, my face is suddenly incredibly puffy, or I can't get my wedding ring off my fingers anymore, or if they have sudden rapid weight gain, say 5 pounds in just 2 or 3 days, that is highly concerning.
Because that weight isn't fat, and it isn't the baby growing. That weight is pure fluid.
Yes. The damaged weeping capillaries are just leaking water out of the vascular space and into the tissues all over the entire body.
That is wild.
When you see that level of systemic involvement, your priority nursing actions immediately shift to intensive maternal and fetal surveillance.
What are we doing for the baby at this point?
We need non-stress tests to check if the fetal heart rate is still reactive and healthy. We need serial ultrasounds to track fetal growth, because that broken placental plumbing often causes severe intrauterine growth restriction.
Because the baby simply isn't getting the nutrients to grow.
Right.
Okay, I want to zero in on one specific symptom that the sources highlight repeatedly. It feels like a massive exam trap and just a critical real-world safety issue.
Let's hear it.
Let's say Maria is sitting in triage. Her blood pressure is 165 over 112. She is rubbing the area right under her right rib cage, and she says, I have this terrible burning aching pain right here. It's radiating to my back. It must be severe heartburn from the spicy food I ate for lunch.
I am putting on my strictest clinical mentor hat right now, and I need every student listening to burn this into their memory.
Okay, I'm ready.
When an OB patient with elevated blood pressure complains of severe heartburn, indigestion, or right upper quadrant pain, do not assume it is last night's lunch.
But don't just give him an antacid.
Do not just hand him a Tums and walk away. This is a screaming, flashing, neon red flag.
What is actually happening under those ribs? Why does it hurt so badly?
It's the liver. Because of the systemic vasospasm and endothelial damage, the liver is suffering from severe ischemia. It isn't getting enough oxygen.
Okay.
Because the vessels are damaged, fibrin deposits start to form inside the hepatic microvasculature, physically blocking the blood flow.
Oh, so it's clotting up inside the liver.
Yes. The liver tissue begins to undergo hemorrhagic necrosis. It is literally bleeding and dying from the inside out.
But the liver itself doesn't have pain receptors, does it?
You're right, the liver tissue doesn't.
Yeah.
But the liver is wrapped in a tight fibrous sheath called Glisson's capsule.
Okay.
As the liver bleeds and swells with edema, it expands. But the capsule does not want to stretch.
Oh, wow. So the liver is ballooning outward, and it's stretching the fibrous capsule to its absolute breaking point.
Exactly. That severe stretching of the hepatic capsule is what causes that acute burning right upper quadrant or epigastric pain.
That is horrifying.
It is a sign of impending liver rupture. If that capsule tears, the mother will bleed to death internally in minutes. You must report that symptom to the provider immediately. It is an absolute Tier 1 emergency.
Understanding the physics of the swelling inside the capsule makes that symptom completely impossible to forget. I will literally never look at heartburn in a pregnant patient the same way again.
Good. You shouldn't.
And that transitions us urgently into the next phase of this disease. Because if severe preeclampsia is the alarm bell ringing, the next two conditions mean the building is actively collapsing.
Yeah, we were talking about Eclampsia and HELLP syndrome.
Right. The sources make it clear these are the big ones.
These are the two most feared complications in obstetrics. They are life-threatening emergencies that require immediate, coordinated, precise nursing action.
Let's start with eclampsia. What's the core definition we need to know?
Eclampsia is the hallmark neurological complication of this disease process. It is defined by the onset of generalized tonic-clonic seizures in a patient who previously had preeclampsia.
So the vasospasm in the brain, the cerebral edema, the leaky capillaries, it all finally crosses a critical threshold, and the central nervous system essentially just short circuits.
That's a perfect way to describe it. The brain simply cannot handle the pressure and the ischemia anymore.
And then they seize.
Yes.
Whoa.
The patient loses consciousness, their body goes rigid in the tonic phase, their back arching, their jaw clamping shut.
And then the clonic phase.
Right. Then they enter the clonic phase, which is the violent, rhythmic, alternating contraction and relaxation of the muscles. It is honestly one of the most frightening things you will ever witness.
I can't even imagine.
And as the nurse, you are the first responder. You don't have time to go find a textbook. You need to know the priority actions by heart.
Okay, coach me. Walk me through it. I walk into Maria's room, and she is actively seizing. What is my literal first physical step?
Step 1, keep the airway clear and do not leave the patient. You hit the call bell, you shout for help, but you stay at that bedside.
Step 2 is getting her into a safe position. Right. And this is where I need to clarify something, because standard first aid says to put a seizing person in the right recovery position.
Right.
But the obstetric sources have a very specific bolded warning against this. They say, right recovery position may compress the inferior vena cava and lead to maternal hypotension and shock.
That is a phenomenal catch, and it's a classic NCLEX trap. Remember, this patient has a massive, heavy, gravid uterus.
Yeah, she's 32 weeks pregnant.
Right. If you roll her flat onto her back or onto her right side, that uterus will compress the inferior vena cava, which is the massive vein returning blood to the heart.
So what happens?
You will completely cut off her cardiac output.
So she's seizing, she's not breathing well, and now her heart has no blood to pump. That's a death spiral.
Exactly. So your step 2 is to immediately turn the patient to a left lateral tilt. Roll her onto her left side.
What if she's thrashing too much to turn her?
If she is seizing so violently that you cannot safely turn her entire body, another nurse must perform manual uterine displacement.
What does that mean?
Meaning they literally put their hands on the pregnant belly and physically push the uterus over to the left side to keep the weight off that vein.
Okay, airway is clear. She is tilted left. What's next?
Step 3, administer oxygen. Apply a non-rebreather mask at 10 liters per minute.
Got it.
Step 4, ensure the padded side rails are up to prevent her from throwing herself out of the bed and suffering a traumatic brain injury.
Wait, while the mother is seizing and turning blue, what is happening to the baby? Because the placenta obviously isn't getting any oxygen during a tonic-clonic seizure.
The fetus is experiencing acute, severe hypoxia. If you're looking at the fetal monitor during a seizure, you will almost always see a sudden loss of variability, followed by profound fetal bradycardia.
The baby's heart rate just tanks.
It plummets.
That sounds like an immediate indication for an emergency crash C-section. We have to get the baby out.
And that is exactly the instinct exam writers will try to exploit.
Wait, really?
Yes. They will give you an option to prepare for immediate operative delivery. But here is the critical clinical reality. You do not rush to an operating room to cut into a mother who is actively seizing, hypoxic, and hemodynamically unstable.
Why not?
Because the maternal mortality risk is astronomical. She will bleed out or code on the table.
So what do? We just watch the baby's heart rate drop.
You focus on the mother, you stabilize the mother first, secure the oxygen mask before helping others.
Like on an airplane.
Exactly. Once the maternal seizure is controlled, usually with medication we will discuss shortly, and the mother's oxygen saturation comes back up, the placental perfusion is restored.
And the baby's heart rate recovers.
In almost all cases, yes. The fetal bradycardia resolves on its own once the mother is stabilized. Only after she is stabilized do you evaluate for delivery.
That is such a powerful lesson in clinical prioritization. But ultimately, you do have to deliver, right?
Yes. The definitive ultimate cure for eclampsia and preeclampsia is the delivery of the fetus and the placenta.
Because it removes the source of the problem.
Right. Once that broken placental plumbing is physically removed from the mother's body, the source of the toxic cytokines is gone, and the maternal vascular system can finally begin to heal.
And here is a clinical rule of thumb from the text. Every convulsing pregnant patient is due to eclampsia until proven otherwise.
Absolutely. Don't assume they have epilepsy. Don't assume they have a brain tumor. Assume eclampsia and treat for eclampsia.
Okay, let's pivot to the other arm of this emergency spectrum, HELLP syndrome.
HELLP syndrome.
The text says this is a severe variant of preeclampsia, and it occurs in about 4 to 12% of patients with severe it's an acronym. Let's break down the letters, starting with H.
H stands for hemolysis. This is the destruction of red blood cells. To be specific, it is microangiopathic hemolytic anemia.
Okay, microangiopathic meaning pathology of the small blood vessels. How exactly does the vascular spasm destroy the red blood cells?
Think back to our broken plumbing.
Yeah.
The tiny blood vessels are spasming, they are narrow, and they are lined with damaged, jagged endothelial cells and fibrin clots.
Right.
As the mother's red blood cells are pumped through these microscopic damaged vessels, it's like sending a raft down a river filled with jagged rocks.
Oh, wow.
The red blood cells are physically sheared apart, fragmented, and destroyed as they try to squeeze through.
The blood vessels are literally acting like a cheese grater on the red blood cells. That is a brutal image, but it makes perfect sense.
It is brutal. Her red blood cell count crashes. She becomes deeply anemic.
What about the EL?
EL stands for elevated liver enzymes. We touched on this with the right upper quadrant pain.
Right, the liver swelling.
Exactly. The endothelial damage and those fibrin deposits obstruct the microscopic blood flow within the liver. This profound ischemia leads to hemorrhagic necrosis.
The liver is dying.
Yes, and the dying, bursting liver cells spill their intracellular enzymes, specifically AST and ALT, directly into the bloodstream. When you draw a liver panel, those numbers will be astronomical.
Which brings us to the final letters, LP, which stands for low platelet count. Why are the platelets disappearing?
Platelets are the body's microscopic patching crew. Their job is to plug holes in damaged blood vessels.
Okay.
Because the mother has massive systemic endothelial vascular damage happening all over her entire body, the platelets are working in overdrive.
So they're just getting used up.
Exactly. They aggregate at the sites of all this endothelial damage, desperately trying to patch the leaky, spasming pipes.
So they aren't actually being destroyed. They're just all being consumed. They are all deployed to the front line. So there are none left floating freely in the circulating blood.
Exactly. The systemic supply drops dangerously low, often below 100,000.
That's bad.
It is terrifying because if she needs surgery or when she delivers, she has no platelets left to form a clot. She is at massive risk for catastrophic hemorrhage and conditions like DIC, disseminated intravascular coagulation.
Now, I saw a trap in the sources regarding HELLP syndrome, and it completely blew my mind because it contradicts everything we've talked about so far.
I know exactly the trap you're talking about. It is one of the sneakiest questions on the NCLBX.
It's that hypertension and proteinuria might be completely absent in a patient with HELLP syndrome.
Yes.
Wait. How is that possible? You just said HELLP is a variant of severe preeclampsia. How can they have a preeclampsia variant with perfectly normal blood pressure and clean urine?
Because the disease process in HELLP is highly targeted. The endothelial damage targets the hepatic and hematologic systems so aggressively and so rapidly that the systemic blood pressure hasn't always had time to spike yet.
Oh, wow.
And the kidneys haven't failed yet. The classic blood pressure and urine signs don't always flag the alarm.
So if I'm the triage nurse and Maria walks in and her blood pressure is 120/80, but she looks awful.
You cannot rely solely on the blood pressure cuff. If you do, she will die.
That is sobering.
You must rely on the lab values and the patient's subjective complaints. If a pregnant woman comes in complaining of severe malaise, nausea, vomiting, and that right upper quadrant pain, you must draw a CBC and a liver panel immediately.
Because if you wait for the blood pressure to spike, you might be waiting while her liver is actively tearing itself apart. That is a phenomenal clinical pearl.
That's one you have to remember.
So knowing what is happening is half the battle. Now we have to talk about how to stop it. We need to talk about the medications.
This is where we shift from diagnostics to interventions. Yeah. Pharmacology is heavily tested here.
And there is one drug that absolutely rules the obstetrics.
Sulfate.
Magnesium sulfate. It's everywhere in the sources.
It is the absolute cornerstone of treating severe preeclampsia and eclampsia. But the most important thing you can learn today is why we give it.
Okay, I'm going to set up the classic trap for you.
Do it.
So my patient's blood pressure is 170/115. We are hanging an IV drip of magnesium sulfate to lower her blood pressure, correct?
Absolutely not.
But her pressure is high.
And I will aggressively correct any nurse who charts that.
Yeah.
This is the #1 most fatal trap in OB pharmacology.
Okay, why?
We give antihypertensive drugs like labetalol or hydralazine to lower blood pressure. We give magnesium sulfate purely, 100%, for seizure prophylaxis. It is not a blood pressure medication.
Okay, let's unpack the why. If it doesn't fix the blood pressure, how exactly does it stop the patient from having a tonic-clonic seizure? What is it actually doing in the brain?
Magnesium sulfate is a potent central nervous system depressant. It works at the cellular level by blocking neuromuscular transmission.
How does it block it?
Without getting too deep into the biochemistry, magnesium competes with calcium at the neuromuscular junction. By blocking calcium, it prevents the neurons from firing excessively.
So it just calms the brain down.
Exactly. It essentially raises the seizure threshold by sedating and calming down that hyperactive short-circuiting brain.
But doesn't it lower the blood pressure a little bit, like as a side effect?
It does cause a very mild transient vasodilation, which might drop the pressure by a few points, but that is a side effect. It is never the therapeutic goal.
Got it.
If you give mag sulfate expecting the pressure to drop from 170 to 120, you will be deeply disappointed and your patient will stroke out.
How do we administer it? Because it sounds incredibly potent.
It is a high-alert medication. It must always be administered via a dedicated IV infusion pump. You never, ever hang it by gravity.
What's the dosage usually look like?
The protocol usually calls for a loading dose, which is a heavy hit of 4 to 6 grams delivered over 15 to 30 minutes to quickly raise the serum magnesium levels. This is followed by a maintenance dose of 1 to 2 grams per hour.
And we stop it as soon as the baby is delivered. Right, because the cure is delivery.
Another trap.
No.
Wait, why not? The placenta is gone.
Just because the placenta is removed doesn't mean the massive endothelial inflammation instantly disappears.
Oh, that makes sense. It takes time to heal.
Right. The mother remains at an incredibly high risk for an eclamptic seizure for days after birth. The magnesium infusion is almost always continued for 24 to 48 hours postpartum.
What does this actually feel like for the patient? Being on a continuous IV drip of a central nervous system depressant for 3 days.
It feels awful. We call it being magged. The patients feel intensely flushed, hot, and sweaty, especially during that initial loading dose.
That sounds miserable.
It is. They feel incredibly lethargic, weak, and heavy. They describe feeling like they have a terrible case of the flu. Their vision might be blurry.
So our job is a lot of patient education then.
Yes. As the nurse, you have to provide intense emotional support and education so they understand why they have to endure it. And while they are enduring it, we have to monitor them obsessively because there is a very fine line between therapeutic sedation and fatal toxicity.
Exactly. You are depressing the nervous system. If you depress it too much, the body literally stops functioning. You must know the priority signs of magnesium toxicity by heart.
What are the exact metrics? What am I checking every hour?
First, the respiratory rate. If the brain is too deeply sedated to send signals to the diaphragm, the patient stops breathing.
What's the cutoff number?
A respiratory rate of fewer than 12 breaths per minute is a critical sign of toxicity.
What about their reflexes?
We check deep tendon reflexes, or DTRs, constantly. The magnesium is blocking the neuromuscular junction.
Right.
If you tap their knee with a reflex hammer and there is absolutely zero response, an absent reflex, it means the neuromuscular junction is entirely paralyzed. That is toxicity.
And the kidneys play a role here too, right? Because the kidneys have to clear the drug.
Yes. Magnesium is excreted almost exclusively by the kidneys. But remember, in severe preeclampsia, the kidneys are failing due to vasospasm.
Oh my gosh, so the drug just builds up.
Exactly. So you must monitor urine output strictly via a Foley catheter. If the urinary output drops below 30 milliliters per hour, the kidneys are not clearing the drug. The magnesium will rapidly build up in the bloodstream, leading to lethal toxicity.
Okay, so I walk into the room. Maria's respiratory rate is 10. Her reflexes are gone. Her urine bag is empty. What is my immediate first action?
You shut off the infusion pump immediately. You stop the drug.
Don't wait for a doctor.
Do not wait. Stop the drip. And then you reach for the antidote. You must never start a magnesium drip without the antidote physically present in the room or immediately available in the med cart.
What is the antidote?
Calcium gluconate. Because magnesium competes with calcium at the cellular level, flooding the system with calcium reverses the blockade.
How do we give it?
The dosage is typically 10 milliliters of a 10% solution, administered 5 slowly over 3 minutes. It will restore muscle function and stimulate breathing.
Stop the mag, push the calcium. Got it. Now, you mentioned earlier that magnesium doesn't fix the blood pressure. So what do we actually use to keep these patients from stroking out? Walk me through the antihypertensives.
We have a few heavy hitters. The first line is often hydrolysine. It is a potent vasodilator given as a slow IV push. It works by directly relaxing the vascular smooth muscle.
What's the nursing implication there? If I rapidly dilate all the blood vessels, doesn't the blood pressure tank?
That is exactly the risk. The primary nursing action is monitoring for severe rebound hypotension.
And the heart rate.
Because the pressure drops so suddenly, the maternal heart rate will reflexively spike, tachycardia, trying to maintain cardiac output to the placenta.
What if we don't want the heart rate to spike? What's the alternative?
Then we use labetalol. This is an incredible drug for OB. It is an alpha-1 and beta blocker.
Wait, a beta blocker? Doesn't a beta blocker normally lower the heart rate? If we drop the mother's heart rate, won't that decrease blood flow to the baby?
That is the genius of labetalol. Because of its specific ratio of alpha to beta blockade, it primarily targets peripheral vascular resistance.
Okay.
It relaxes the spasming blood vessels and lowers the blood pressure without significantly decreasing the maternal heart rate or cardiac output. It protects the mother's brain while keeping placental perfusion steady.
That is a perfect physiological explanation. What about oral medications?
For maintenance or less acute severe pressures, we use nifedipine. It is a calcium channel blocker.
How does that work?
It prevents calcium from entering the muscle cells of the blood vessels, causing systemic vasodilation. Because it works systemically, the patient will often experience flushing, headaches, and dizziness when they stand up.
So fall precautions are a must.
Absolutely. You have to implement fall precautions.
And what is the absolute last resort? Like the nuclear option for blood pressure?
For a true, uncontrollable hypertensive crisis, we use sodium nitroprusside. It is an incredibly potent, rapid-acting vasodilator given via continuous 5E infusion. It works in seconds. But there is a massive, highly testable nursing action required here.
What is it?
Nitroprusside degrades very rapidly when exposed to light. When it degrades, it literally turns into cyanide.
Oh my God.
Yeah. You must wrap the IV solution bag and the tubing in foil or an opaque material provided by the pharmacy. If you see a question about a foil-wrapped IV bag on the exam, it is nitroprusside.
Foil-wrapped IV bag equals nitroprusside. That's a great memory anchor. Now, we've talked about treating the crisis. Is there anything we can do to prevent the plumbing from breaking in the first place?
Actually, yes. Evidence-based practice has revolutionized prevention in recent years.
Really? With what?
For patients with high risk factors, like a history of preeclampsia, chronic hypertension, or diabetes, we now strongly recommend low-dose aspirin, usually 81 milligrams daily, starting between 12 and 16 weeks gestation.
Aspirin is an antiplatelet. How does that prevent the vessels from spasming?
It alters the balance of prostaglandins in the body. It specifically inhibits the production of thromboxane, which is a potent vasoconstrictor and platelet aggregator produced by the placenta.
So it stops the clamping.
Exactly. By starting low-dose aspirin early, we keep the blood slightly thinner and prevent those microscopic clots from forming in the spiral arteries, allowing better placental invasion.
That is fascinating. We are chemically forcing the plumbing to stay open. Now, there is one more crucial medication we have to cover, and it's for the baby.
Yes. Betamethasone.
What does that do?
If the preeclampsia is so severe that we are forced to deliver a premature baby, say at 2 weeks, we know that baby's lungs are not fully developed. They lack surfactant, the soapy substance that keeps the air sacs open.
So we give the mother steroids.
Yes. Betamethasone is a potent corticosteroid administered via an intramuscular injection to the mother. It rapidly crosses the placenta and signals the fetal lungs to drastically accelerate surfactant production.
How is it dosed?
It is given in 2 doses, 24 hours apart. The goal is to delay delivery for at least 48 hours after the first injection to give the steroid time to work.
But what if we can't wait 48 hours?
Even a few hours of exposure provides significant benefit to the premature neonate's respiratory function.
Okay, the pharmacology makes so much more sense when you explain how they work. But knowing the meds isn't enough. We have to know how to assess the patient to know when to give them.
Absolutely not. You are the vanguard.
Let's talk about clinical skills. Because a safe nurse doesn't just hang an IV bag and walk away.
You have to predict the complications before they happen. And in severe preeclampsia, the 2 most critical physical assessments for central nervous system irritability are deep tendon reflexes and ankylonus.
I want to get granular here. Walk me through the exact physical motion of assessing the patellar reflex. How hard am I hitting the tendon? What am I looking for?
You want the patient relaxed. If they are sitting on the edge of the bed, their legs should be dangling freely.
What if they're in bed?
If they are lying supine, put your arm under their knee to slightly flex it and support the weight of their leg. You take your reflex hammer and you strike the patellar tendon, which is the thick band right below the kneecap,
How hard?
with a firm, brisk, swinging motion of your wrist. You don't tap it lightly, but you don't smash it.
What happens biologically when I hit that tendon?
You are stretching the muscle spindle. That sends a signal to the spinal cord, which immediately sends a motor signal back, causing the quadriceps muscle to contract and the leg to kick forward slightly.
And what is a normal kick? How do we grade it?
A normal, expected, healthy response is documented as a grade 2 plus bag. It's a noticeable, moderate kick.
We talked about grade 0. That's an absent reflex, indicating magnesium toxicity. The signal is blocked. But what if the brain is irritated by cerebral edema?
If the upper motor neurons in the brain are irritated by vasospasm and swelling, they lose their ability to send inhibitory calming signals down to the spinal cord.
So the signal is too strong.
The reflex arc becomes hyperexcitable. If you strike the tendon and the leg kicks out violently, almost jumping off the bed, that is a brisk hyperactive response. We grade that at 3 plus N.
And what is a 4 plus M?
A 4 plus is dangerously hyperactive. The muscle might even flutter after the kick. If you see a 4 plus reflex, you are looking at a central nervous system that is wound incredibly tight. It is a massive warning sign of an impending eclamptic seizure.
Which naturally leads us to testing for ankylonus. What does clonus actually feel like in your hands?
To test for clonus, you have the patient lie supine with the knee slightly bent. You support their leg with one hand.
Okay.
With your other hand, you grasp the bottom of their foot and you briskly dorsiflex it, meaning you rapidly push their toes backward, pointing toward their shin, and then you hold slight pressure there.
In a normal patient, what happens?
Nothing. You push the foot back and it just stays there under your hand. When you let go, it smoothly drops back down. No clonus present. Negative finding.
But if they have that hyperexcitable, irritated nervous system...
When you push the foot back, the stretched calf muscle violently misfires. You will literally feel the foot rhythmically, involuntarily beating and jerking against your hand.
Beating against your hand.
Yes. It feels like the foot is pulsing back and forth.
That's a vivid, terrifying image.
It is. If it beats 2 or 3 times and then stops, we call that transient clonus. But if it continues beating rhythmically over and over, as long as you hold pressure, that is sustained clonus.
And that means what?
Sustained clonus confirms severe, profound CNS involvement. That patient's brain is teetering on the edge of a seizure.
So if I walk into a room and my patient has a blood pressure of 165 over 110, a terrible headache, 4 plus reflexes, and sustained ankle clonus, she is powder keg.
Exactly. Which brings us to our final and perhaps most overlooked priority nursing action. Environmental control.
Environmental control, you mean like adjusting the thermostat?
I mean completely locking down the sensory input of that hospital room. If you have a patient who is a powder keg, the slightest spark can trigger the explosion.
Oh, I see.
The room of a severe preeclampsia patient must be strictly controlled.
What does that look like practically?
The room should have dim lighting. Turn off the bright overhead fluorescence. It must be as quiet as possible.
So close the door.
Close the door to block out the noise of the nurse's station. Turn down the volume on the monitors so they aren't constantly shrilly dinging.
What about family members?
You must limit visitors, usually to just one calm support person. You don't want 5 loud family members crowded around the bed arguing.
You essentially want to make the room the most boring, sensory-deprived environment physically possible.
Yes. A sudden loud noise, a bright flash of light, or high emotional stress can literally be the final sensory trigger that pushes a hyperreflexic brain into a full tonic-clonic seizure.
Wow. Are there any physical safety measures for the bed?
You must ensure that the padded side rails are up and that working suction equipment and an oxygen mask are immediately available and set up at the head of the bed.
So you don't have to go looking for them.
Exactly.
Yeah.
Because if she does seize, you don't have time to go hunting for a suction canister in the hallway. You have seconds.
Wow. We have covered an absolute mountain of clinical ground today, from the microscopic spiral arteries to managing a massive generalized seizure.
It's a lot, but it all connects.
It really does. To wrap this up, let's distill this into the absolute must-knows. If you, the listener, only remember 5 things from this entire deep dive to take into your NCLEX or onto the clinical floor, let it be these.
Number 1. The 20-week mark is the absolute ironclad boundary separating chronic hypertension from gestational hypertension.
Yeah.
Pin that date to your brain.
Number 2. Preeclampsia is not just a high blood pressure disease. It is a multi-system endothelial disease caused by broken placental plumbing. The high blood pressure is just a symptom of the systemic vasospasm.
Number 3. Magnesium sulfate is administered purely for seizure prophylaxis, never for blood pressure reduction.
And we monitor for toxicity, right?
Obsessively. Respiratory rate under 12, urine output under 30, and absent DTRs. And you must always have calcium gluconate readily available as the antidote.
Number 4. Severe heartburn or right upper quadrant pain in a hypertensive pregnant patient is not a GI issue. It is a screaming warning sign of liver swelling, capsule stretching, and impending hemorrhagic necrosis associated with HELLP syndrome.
And number 5. The definitive cure for preeclampsia is the delivery of the fetus and placenta. But the mother remains at an incredibly high risk for eclampic seizures for 48 to 72 hours postpartum.
Do not drop your guard just because the baby is in the bassinet.
Never.
Which brings us to a final provocative thought, an insight that bridges the gap between just passing a test and providing truly elite, lifelong patient care.
Look at the recent data highlighted in our sources. Historically, we treated preeclampsia as a temporary pregnancy complication.
Right? Like once the baby was out, it was over.
Once the baby was born and the blood pressure stabilized, we sent the mother home and considered her cured. But the new research shows that is dangerously incorrect.
The sources explicitly state that hypertensive disorders of pregnancy are directly associated with massive long-term cardiovascular risks later in the patient's life.
We are talking about chronic hypertension, hypercholesterolemia, severe obesity, and type 2 diabetes manifesting years after the pregnancy.
Yeah, it's so unfair.
Think about the physiological trauma we just spent the last hour discussing. The widespread endothelial damage, the vascular inflammation, the systemic stress that doesn't just vanish without leaving a scar.
So it does permanent damage.
That damage permanently changes the maternal vascular trajectory. The pipes are forever altered.
So the next time you are preparing discharge paperwork for a patient who just survived severe preeclampsia, realize you aren't just sending a mom home with a new baby and instructions on how to breastfeed.
You have a vital, fleeting window to educate her about a lifelong cardiovascular threat.
The question is, are we, as healthcare providers, doing enough in that postpartum room?
Are we warning these patients that they need to see a cardiologist in 5 years? Are we setting them up for a lifetime of proactive heart health? Or are we just waving goodbye because our obstetrics job is done?
It is a profound responsibility, and it is exactly what separates a nurse who just passes meds from an elite clinician who changes lives. You have to see the bigger picture.
Absolutely, you really do.
As you step away from this deep dive, remember that obstetrics is dynamic, it is complex, and the plumbing can break in ways that threaten 2 lives simultaneously. But now, you know how to read the patterns.
You know the why behind the alarms.
Keep applying that critical thinking, focus on the high-yield physiology, and you are going to be a profoundly safe, incredible future nurse. Keep asking why, and we'll catch you on the next deep dive.